first of all, congratulations, students. You have gone through one of the most difficult classes you've ever had, and you've had a tough last year and a half. I applaud your tenacity and your willingness to be flexible. Welcome to public health. And we're real proud of all of the work that you've done. This has been a tough class. I also want to thank Dr. Tahara and Coral Matar. The work that they put in, it can't be measured. The amount of work they've put in, and without Coral's help, this would have been really tough for Dr. Tahara. Keep in mind also that a lot of this work is done months prior. So thank you, Denise and Coral, for all of your hard work with that. And I also want to thank George Contreras and Ari Markinson. Apparently they've been pretty valuable for the class as well. Dr. Tahara, thanks for everything you've done with this group, and looking forward to the presentations.
Thanks very much, Dr. Kittleson. So because this is a class, of course, I have to have a couple of things to say before we get started. However, while I'm doing this, what I'd like to say is, first of all, if there are alumni here, if you're HPM alumni, please just put it in the chat and tell us what your project was. If you are just alumni from the School of Health Science and Practice, please just, we'd like to give you a shout out. Thank you, all of you, for coming. I know I saw a few names. I saw Patty Reynolds and Dawn French, who happen to have been on the same project. So that's for a few years back. So just quickly scanning. And also Professor Markinson is on the call, so thanks very much. So I'm going to just sort of walk you through what Capstone is. I'm going to just make a couple of comments, and then I, of course, have a slideshow. No class would be complete without one, right? So first, I also want to alert all of you that Wednesday and Thursday night, the other capstones from the other programs are going to be via Zoom. So on Wednesday night, we have health behavior and community health. And Thursday, we have both biostatistics and epidemiology capstones. So I hope you'll join us for those others. And a lot of us were already at the earlier one with environmental. So we've got a great week scheduled. So Capstone is the culinary applied research experience for MPH students before graduation. In Capstone, students have the opportunity to really integrate and apply the knowledge and skills they acquired in the program to real-time public health challenges and community stakeholders. They also have the opportunity to hone other skills such as project management, public speaking, and systems analysis. They create concept maps, flowcharts, logic models, and ideate projects and develop solutions. In health policy and management, the students have the opportunity to really look through the lens of the patient or the user's experience and follow their journey. And that's the lens that they use to address the public health challenges and work with community-based organizations. Although this semester they didn't have the opportunity to work with community-based organizations, all 3 Capstone teams had the opportunity to work with stakeholders in the respective fields. Before the students present, I want to share with you a brief look at what our process was. The students used what we refer to as the 4D strategic design approach to their research. This approach enables them to really not be constrained by traditional boundaries and barriers, and also consider the impact on the demographics studied. It's a human-centered design approach where they start with empathy. And this requires the students to zoom out to really understand the ecosystem and the stakeholders and the context, and then zoom in to really address the specific problems. So what's Capstone? Gosh, a lot of people scratch their heads. I assure you it's not free-falling, although at times it probably felt that way. But in fact, Capstone is the last stone that holds everything else in place. And for the students, it's really all of the knowledge that they acquired in this program. It's also an opportunity and, of course, process. No course with me would be complete without a flow chart. So I want to briefly just sort of tell you a bit about what this process is, the 4D, which is called the human-centered design. So as you see, we have four stages: discover, define, design, deliver. You also see we have this divergent and convergent thinking. So the divergent thinking really is the place where we ideate. We sort of expand, explode, look at the market. No ideas are looked over. And each time we go through the divergent part, we then come back together with convergent thinking. We think about how we either apply what we learn or how we're going to measure it or how we can think about and structure this. So this is really an iterative and a cyclical process. And the goal is to really help tell the story about the public health challenge that we are looking at. So the discover is where you study the context, the ecosystem, what's working, what's not, where's there an opportunity. Define is really where is what is out there and why it's working, where there are gaps, where there are insufficiencies, and how will we study this problem. Design is what do we learn, now what? Where are some of the infrastructure needs? What are some of the next steps, actions, and innovations? So what's the purpose? Well, the purpose really is for us to develop creative leaders who can collaborate and innovate to solve real-time public health challenges. And what Capstone is not a shouting match or heavy lifting. Everybody participates equally. So where do we start? Obviously with public health, and there are millions and millions of public health challenges for us to study. The students start with a problem statement and then develop a research question. They also use literature both through the computer and also those are books for those of you who don't recognize what they are. They work on team building and idea generation, and they make connections to create a new narrative for the problem that they're studying. So they also conceptualize their project using whiteboard or whiteboard-like objects. Oh, sorry, that was Capstone 2021. COVID hit. So what does our process look like? From week to week, this became our reality, or maybe even a little bit of Hollywood Squares. What I'm showing you here is actually how we reset to collaborate in a virtual setting. We used a program called Miro, which is a collaboration tool. It's basically a virtual whiteboard. What you see here is how the students actually worked on their projects. So this is one of three. Each student has their own infinite whiteboard. And what you see are they have various frames and various diagrams, drawings, photos, things, all things that they would be using in their program, in their project. The really cool thing about this is that they can work on it in real time. They can be on a Zoom call, they can be on a telephone call. They don't even need to be in the same room, or they can work asynchronously. All of their comments, all of their changes are all recorded. And so when students jump back onto the whiteboard, they can actually see what messages were left to each other. I'm going to just briefly show you a video. Let's hope this works. Just part of the video.
Miro is a whiteboarding platform where your team can create, discuss, and share their work using the simplest tools. It fits right into your team's current workflow. They can add everything from spreadsheets to interactive prototypes to the board. And don't be afraid to run out of space. All you need to do is zoom out to see the big picture. To start a conversation, go to the collaboration toolbar in the bottom left. Suppose your colleague left a comment on the board. He wants your input on a visual for the project he's working on.
So you can see that the students can really work together or independently, and they really had the opportunity to use this to replace being in person. They also put their posters together for each one of the three projects, and these will be available in the breakout rooms. These will be available in the breakout rooms after our presentations. So I want to thank everybody. I want to thank our first responders and our healthcare colleagues and all those who supported the students at home with their projects, and enjoy the presentations. Last thing that I want to do right now is I'd like to just thank the faculty for their support and hard work and supporting the students throughout the program. I especially want to thank Professor Matar and Professor Contreras, happy birthday, by the way, and our chair, Mark Kittleson. Of course, behind the scenes, Cindy Jakubowski. A shout out to Taylor Gerber, who prepared all the marketing communications and who was just selected as one of 10 fellows for the prestigious John Solomon Fellowship for Public Service. Go Taylor, go you, thank you. I also would like to give a shout out to Mike Crowder and to Educational Media, especially Mike Frankfurter, who helps students with their visuals. And I'd also like to take a minute for us to remember our friend and educational media specialist, Christian Sheridan, who left us too early. Our condolences to his family and to his friends in educational media. Chris, you were definitely missed this capstone and you will be missed. Thanks for joining us. Now I will turn the program over to our students.
Good evening, everyone. Our team is presenting on our project, Improving Hospital PPE Surge Capacity Through Supply Chain Resilience. We will introduce ourselves.
I'm Manasiari.
Valerie Favola.
Julie Henry.
Erica Payne, Erica Gilwin.
Stephanie Pastrin.
Jacqueline Schaefer.
And O'Brien Tomlinson.
And next, we will show you a video to give you an overview of our project.
The COVID-19 pandemic has been a great challenge for the world, affecting every country and revealing underlying weaknesses both globally and at all levels of society. Due to the rapid spread of the disease, many global-level exchanges were disrupted, from international travel to the import and export of goods. A major problem that has emerged is the shortage of medical-quality PPE, or personal protective equipment, which has directly endangered healthcare workers by potentially exposing them to infection from COVID-19. Hospitals have had to grapple with what to do in the face of dwindling PPE supplies, not knowing when they will be able to get more. As a result, healthcare workers have been forced to ration and reuse PPE and sometimes go without. We found that there have been 457,666 cases of healthcare personnel contracting COVID-19 and 1,522 deaths. The PPE shortage from supply chain failures has no doubt played a part in some of these. We knew this was a problem when in March 2020, the World Health Organization estimated that 89 million medical-grade masks, 76 million examination gloves, and 1.6 million goggles would be needed each month worldwide to fight COVID-19. They estimated that the global PPE industry must increase their manufacturing capacity by 40% in order to meet demand. While it's simple to state that the global PPE supply chain must increase by 40%, to achieve this is another matter entirely. The situation is this. Hospitals are obligated to provide PPE to their healthcare workers to protect them from infection, but the global supply chain that the hospitals depended on broke down. Hospitals have had to search desperately for ways to cover the gap in PPE supplies, all while dealing with never-before-seen surges of severely ill patients who are carrying a highly contagious novel virus. In our project, we have looked at how hospitals generally prepare for emergencies and surges of patients, examined the frameworks and regulations that guide this planning, and investigated where the breakdowns occurred from start to end of the PPE supply chain. We have looked at what different hospitals and healthcare organizations did to acquire their needed PPE and maintain operation and quality patient care in extremely trying circumstances. We have utilized our understanding of emergency management, supply chain management, and systems design to identify common challenges and common strategies for success from case studies and use them to form our recommendations for best practices. As this COVID-19 pandemic continues towards its end, many more lessons will surely be gleaned. The global community cannot afford to be so caught off guard again. We must address the perils of vulnerable supply chains and consider how to form enduring supply chain models that will not fail when faced with another global emergency like the COVID-19 pandemic.
As you saw, our project is focusing on PPE shortages caused by supply chain failures. PPE is defined as equipment worn by a person to protect themselves and minimize their chances of being exposed to a hazard that could cause them serious illness, injury, or death. Next. We use the 4D approach to this project, which has 4 categories: discover, define, design, and deliver. This approach helped us to connect to the human experience and who was affected by PPE shortages the most, namely healthcare workers. Next. In order to understand PPE shortages experienced by hospitals, we prioritized identifying the frameworks of public health and emergency management that hospitals use for guidance. The frameworks of public health are the 10 Essential Public Health Services, Healthy People 2030, and the United Nations Sustainable Development Goals. Examples relating directly to our project are the 5th Essential Public Health Service is to develop policies and plans that support individual and community health efforts. An aspect of social determinants of health is what makes up Healthy People 2030's program. And goal 9 of the Sustainable Development Goals is to build resilient and sustainable infrastructure, which includes supply chains. The frameworks of emergency management are the 4 phases of emergency management, the National Incident Management System, and the Incident Command System. Next. We will explain a little more about the 4 phases of emergency management, which are a cycle made up of mitigation, preparedness, response, and recovery. Next.
The Incident Command System, a part of the National Management System, is another critical framework of emergency management. There are 5 sections in Incident Command: command, operations, logistics, planning, and administrative finance. The diagram on the right defines each section. Next.
Regulations given by federal and local agencies provide guidance and accountability to hospitals and healthcare practices. These are the Centers for Medicare and Medicaid Services and the Joint Commission, which requires hospitals to have an emergency operation plan. An example of local regulation is the New York State 90-day PPE stockpile requirement. And lastly, it's Assistant Secretary for Preparedness and Response, which is a federal guidance organization. Next.
As a response to an emergency situation, a hospital will activate their incident command system. It is typically activated when routine operations are overwhelmed by the severity, complicated nature, or fast-paced development of an emergency event. Anytime the ICS is activated, communication is crucial to a successful emergency response. The concept of surge capacity can be described as achieving a balance between the resources available and the needs of the hospital by providing staff, stuff, structure, and systems in a quick and effective manner. An efficient surge capacity is important because it enables a hospital to effectively serve their community by reducing mortalities and injuries in an emergency situation. But when hospitals have a limited supply of a critical care item, such as PPE, their ability and capacity to provide needed care to their community is severely restricted.
Based on this research, we study the following question. In what ways can system design, emergency management principles, and supply chain management strategies enable hospitals to ensure that their PPE supply chain is resilient, dependable, and functional? Next. After preliminary research was completed, a concept map and logic model were developed. Our concept map is displayed here with key areas being stakeholders, regulations, emergency planning, and problems. Relevant research for this literature review include thorough research into areas of frameworks and regulations for emergency preparedness, supply chain management, system design, hospital surge preparedness planning, and case studies for how hospitals have been managing their PPE during surges in the COVID-19 pandemic. This was done through a review of a multitude of published articles and an aforementioned topic areas. Next.
During a pandemic such as COVID-19, the global supply chain disruptions arose from several combinations of unintentional and unpredictable events in many places in the upstream supply network, including manufacturers, raw materials, and logistics, as well as the downstream network. Before the pandemic, almost half of the world's medical face masks were sourced from one country, which unfortunately was the first country to be affected by COVID-19. As a result, supply chains began to fail as exports stopped, including PPE. So as we can see from the pie chart, in 2017, China was responsible for sourcing the world by 41%. Next.
So several factors contribute to the disruption in downstream network. First, many healthcare providers adopted the vendor-managed inventory system, which relies on just-in-time delivery to drive efficiency in the supply chain. This model worked smoothly pre-COVID-19 due to the fact the model has the ability to reduce cost and eliminate existing inventory of supplies. But during COVID-19, the model insufficiently faced difficulties meeting the surge in demand due to limited inventory. Moving to upstream network, which also has a common factor that also affected the downstream. First, the lockdown, as mentioned in the previous slide, that China produced almost 50% of masks used in the world. And due to the lockdown to prevent spread of COVID-19, this resulted in disruption and shortages of PPE throughout the world. The transportation network was also affected by lockdown and shut down international flights and restriction on cross-border travel and shipping. And finally, shortages of raw material to create PPE. Next, the supply chain best practices. So once the pandemic started, many healthcare systems like Banner Health, Duke University Health System, and Mayo Clinic took approaches to solve supply chain problems. They used self-distribution model for PPE and other difficult to secure goods. They collaborated with local manufacturers to create recycled gowns and contracted with local developers specialized in 3D printing to print face shields and masks. And to reduce PPE use by clinician and patient, they relied on telehealth services in all COVID-19 facilities. They collaborated with GBOs, but Banner Health and its GBOs did something different and acquired 20% interest in Prestige America Tech to mitigate potential delays and boost future supply assurance. And finally, at the Mayo Clinic, the supply chain staff introduced inventories with the latest technologies powered by advanced analytics to bring more control and visibility over demand-based inventory and logistics for products. Moving to innovation and technologies to improve supply chain management. First, a barcode tracking system to predict demand expiration dates of materials and storage and help improve readiness for a hospital. Second, the blockchain technology that works as a connector between buyer and supplier through a decentralized shared database that record transactions and track properties through peer-to-peer network of computer rather than centralized authority. The technology will help to improve linkage and productivity by automating the task and leveraging the direct connection between the supplier and the hospital. Decontamination system using hydrogen peroxide to sterilize N95 respirator, as one device can sanitize up to 5,000 units of N95 respirators in 2.5 hours. And the last technology that has been used and approved by the FDA is 3D printing due to simplicity of creating one product and switching to another product without much modification. Next.
During the pandemic, hospitals would commonly activate their incident command system well before there was a COVID-19 surge in their area. This allowed ICS to focus on multiple other issues ahead of a surge, such as PPE acquisition or identifying physical locations that could be used to accommodate an influx of patients. We typically see someone in an executive leadership position fulfill the role of incident commander. This could be someone in a clinical or non-clinical position, although having someone in a clinical position as the incident commander could take away needed clinical capabilities during a patient surge. A best practice that was observed was to have someone for procurement or supply management be on the ICS. This enabled direct communication with the ICS and update the team on current PPE numbers, as well as struggles with acquiring PPE and determining what is working and what is not with PPE procurement. Anytime the ICS is activated, communication is crucial to a successful emergency response. The COVID-19 pandemic was no exception, with meetings needing to be held at least daily. A living document was also shown to be helpful in centralizing information and tracking the fast-paced changes. A significant problem during the pandemic was hospitals' inability to surge up their PPE. This left healthcare workers to reuse PPE for many days, and in some cases use PPE that did not provide adequate protection. This no doubt played a role in healthcare workers contracting and dying of COVID-19. Healthcare workers lost their coworkers to COVID-19 infections. This can incite fear among healthcare workers and lead to workplace abandonment, leaving us as a society with less healthcare workers to fight the pandemic. An inadequate amount of PPE also led to healthcare-acquired infections for patients, thus spreading COVID-19 further. Prior to COVID-19, the maximum surge capacity for hospitals was 35%, which was shown to be grossly under what was needed. During the pandemic, New York State mandated a minimum 50% surge capacity with the ultimate goal of 100%. Next.
Procurement departments in hospitals are in charge of purchasing a substantial variety of equipment and supplies at affordable prices. With sudden increase in patients and the adaptation to new protocols, various challenges arose, which include increased pricing of PPE supplies, proper sourcing, supply quality security, and fast delivery. A group purchasing organization is an entity from which hospitals purchase their supplies, save and negotiate discounts with manufacturers, distributors, and other vendors. GPOs improve efficiency, effectiveness, and ensure valuable support during supply shortages. Hospital coalitions represent a strong cooperation between member entities where they work together to procure and source supplies. With domestic manufacturers, these local resources, flexibility, and rapid response aided healthcare workers, facilities, and some examples include distillers producing hand sanitizers and small shops transitioning from aprons to masks. Next.
Some PPE utilization tools and models are the burn rate calculator, which is a spreadsheet offered by the CDC, and that is used to enter the full boxes of each type of PPE in stock and total number of patients to help calculate the average consumption rate, also known as the burn rate, for each type entered. The economic order quantity model, which is the ideal order quantity a company should purchase to minimize inventory costs such as holding costs, shortage costs, and order costs. And the two consumption models that vary based on type of PPE and whether they need to be discarded after one use. Now we will discuss our recommendations for hospitals based on analysis of common elements of our research. Some of the most important findings were the importance of diversifying sources of PPE, especially domestic-based sources. This addresses many risks associated with dependency on a fragile global supply chain. Also, use the burn rate calculator and other PPE utilization tools to model various scenarios, such as routine versus mass casualty versus pandemic influenza versus pandemic coronavirus. When it comes to protocols on PPE preservation, it is important to train widely across all hospital staff so they know beforehand how to use PPE if another shortage occurs. Next.
Our research showed many examples of community partnerships. Local businesses that did not normally deal with PPE changed their operations to help in any way they could. One example is how some businesses partnered with hospitals to make face shields using 3D printing. There were limits because a small business cannot supply on an industrial scale, but for their local area hospitals that these businesses partnered with, they made a difference. This is why we recommend community asset mapping. Community assets can include physical assets, associations, institutions, local economy, and the skills of individuals. Each category should be uniquely assessed for each community. An example of a critical community institution is the local health department, which hospitals closely collaborate with in addressing any major health issues that are affecting the community. Next.
Some additional recommendations are to reevaluate the hospital emergency operations plan and the PPE stockpile policy. For example, how much to have on hand going forward after COVID-19. Hospitals also need to maximize effectiveness of the hospital incident command system to help enhance communication and appointing the emergency department as a forward command to be in control of COVID-19 operations. Also, hospitals should not suffer PPE shortages in the same way again. Many of our rec focus on internal actions hospitals can take because this is what hospitals can control. Our rec leader will be greater PPE supply chain resiliency and efficiency in the hospital system. The time is now and it can wait no longer. Although the COVID-19 pandemic is still active, hospitals must take meaningful steps to prepare for the next major pandemic, not if, but when it will next occur. Thank you for listening to our presentation.
We'd also just like to take a moment to thank Dr. Tahara, Professor Matar, and Professor Contreras. Happy birthday to him. Mr. Shapiro, Dr. Madeline, and Mr. Savini from Montefiore Health System, as well as Professor Erica Makish from the Writing Center. And on the next slides are all of our references if you have any additional questions. Thank you.
Thank you, team. Nice job.